Sayın hocalarım, Türk Nöroşirürji Derneği'nin çok kıymetli üyeleri, Türk Nöroşirürji Derneği'nin planladığı ayın konuğu projemizde bu ayki konuğumuz Profesör Osama El-Mefti bizlere jugüler foramen lezyonları ve cerrahisi hakkında bilgi verecekler. Kendileri bu ayın konuğu programımıza kabul ettikleri için kendilerine çok teşekkür ediyoruz. Ağustos ayının konuğu Profesör Jack Morcos olacak Miami Üniversitesi'nden. Bu programda, bu sunumda Profesör Necmettin Tanrıöver moderatörlük yapacak. Ben şimdi çok kısa olarak Profesör El-Mefti hakkında kendisine teşekkürlerimizi iletmek istiyorum. It's a great honor as usual for us to welcome Professor El-Mefti as our guest. And I would like to express his massive support to Turkish neurosurgery. And also, we have also built a strong bridge with him on this long journey. He will always be a highly respected mentor in our lives. Now, I will leave my words to Professor Necmettin Tanrıöver, who will lead this conference. Please, Professor Necmettin Tanrıöver.
Yeah, good evening, everybody, my colleagues. On the behalf of the Turkish Neurosurgical Society, first of all, I would like to welcome all of you to our second of the monthly webinars, our webinar series, which is on, as you all know, meeting with the Masters of Neurosurgery. Today, following Professor Mahmut Gazi Yaşargil, last month's honorary lecturer, we have another esteemed neurosurgeon from the United States. Almost everybody knows Osama El-Mefti. He's currently the director of skull-base surgery in Harvard Medical School in Boston, Massachusetts. And as we all know, it's almost impossible for me to explain everything about him in 5 minutes. So I'll give just my view, my humble view about Professor. As we all know, Professor El-Mefti dedicated his whole life, or his whole professional career on the development of skull-base surgery, advancement of skull-base surgery. It is clear, and he is truly the master. I would change the word master to a pioneer, because he is the pioneer of the skull-base surgery, one of a few, I believe, in the field of neurosurgery, and we owe him a lot. So all neurosurgeons around the world learned, benefited from his videos, his experience, his seminal articles. I will give some examples of them. He is a prolific writer. What I believe is he's a scientist, a true scientist, not just a brain surgeon, not a neurosurgeon. Enormous contributions. I just look at his biography, over 500 publications, over 236, now maybe 250, I'm not sure, peer-reviewed articles, and among them, there are seminal papers about that. What we have learned about him, just a view of mine, a lot. It's almost impossible for me to say everything, but I made a list. Let me just start one. At the end of 1980s, before our residencies, etc., he explained the exact application of one-piece cranio-orbitozygomatic craniotomy, or the approach itself. Then comes the posterior petrosal approach. He didn't stop. He just redefined the combined petrosal approach, which I believe it should be mentioned, El-Mefti's approach. He added the anterior petrosectomy. He's the pioneer in that, what I believe, added the anterior petrosectomy into the posterior petrosal approach. Management of chordomas is another area. Clinoidal, best classification of clinoidal, best classification of diaphragmacellar meningiomas up to date, without any hesitation. I can say he introduced the concept of suboccipital cavernous sinus, transcondylar approach there, exposing the vertebral artery, etc. And one of the most important things I would say, the venous considerations. Of course, these are not all venous considerations, I mean, in skull-base surgery. He explained about glomus jugulare tumors. Last thing about the papers, he's not staying with the lateral or posterior or posterolateral. He's working on 360 degrees. Of course, we may hear something about endoscope, but he explained about the clivectomy, anterior clivectomy. So he worked about scabies from all angles. So today, Professor Al-Mefti, we are very lucky. We'll talk about the surgery of the jugular foramen region, and we are happy to have him once again. And Professor Al-Mefti, on the behalf of the Turkish neurosurgical community, not society, but the community at large, it's my honor to have you here. It's our privilege. We are learning, and we are still learning from you. Thank you so much for participating this webinar. Just a few words about the lecture itself. Now, following the lecture, we'll have about 10 minutes to address your questions to professors. So we may get your questions about the lecture. You can type it in, and then I will try to ask him. And now I would like to leave the floor to Professor Al-Mefti just after repeating this slide. I chose this slide, and you may see, just a moment. I'm not sure why I cannot. 1 second, please. 1 second. Can I share my slide again? Just a moment, please. You may see all of the Al-Mefti collection, the videos on websites, but just to the young neurosurgeons as well as for us, know the anatomy. Number one, I'm so happy. Number two, understand the tumor in relation to anatomy. Learn the operative approaches. I believe the time is to go to the lab. Number three, match the surgical approach to the tumor and its predicted distortion of anatomy. It is so much. This slide explains so much. And once again, Professor, thank you so much for teaching us. And we are happy to have you here. Thank you.
My slide is shared, no? You don't have, okay, hold on. Nesmettin, Emil, Hakan, how great to see you, and thank you. I am honored and I am thrilled. You know, I love Turkey. So it's so good, and thank you for this opportunity. Why it's not advancing? I think Istanbul is the most beautiful, I believe, not saying, most beautiful place on earth. And I think it is because the people are the most lovable, great, graceful people on earth. So I tell you, I have so much a good memory in Turkey, and I can't wait till come back again. So hopefully the corona will go away. I just thanks Dean Kellick for the opportunity. I was with the first year medical student in his school, and I wish I could get them all to go in neurosurgery. Uh, there is something very special about Turkish neurosurgeons. They're good. So, and they're inspiring. Now, here what's happening. You know, there is a $3.5 trillion United States alone, not the rest of the world, spend every year in 1 year on healthcare. Healthcare became the biggest industry, money making, profit searching things. And like all industry, they go by this theory. This is Taylor back in 100 years ago, written a book for all the company, for all the business, for all the industry. And it's called the scientific management theory or guideline, that you always have to analyze and synthesize. You need productivity and efficiency. You need to standardize everything. You need to have best practices and guideline. It has to be a cost effectiveness. You have to eliminate the waste. That sounds very familiar, that you're hearing that from your chief of the hospital. That's what's happening everywhere. Industrialization of medical care. And in this theory, there is disdain to particular worker of special skills. We don't want anybody with a special skill. We don't want anybody with talent. We don't want anybody who could do things other people cannot do. We want people to push a button. We want people to pass a catheter. Anybody could do it. But neurosurgery, like this great man developed, need talent, need personal skill, need training, need special people. We're top guns. And this place is a beautiful place. It's the sky for Top Gun, the jugular foramen. It is a neurosurgical territory. I was very disappointed the other day on one of the big lectures where a neurosurgeon endovascular presenting a beautiful work, a beautiful presentation. And when he came in, says, well, when our ENT colleague give us glomus, we embolize it. Where's the neurosurgeon? Jugular foramen is a neurosurgeon territory. It needs neurosurgeon, but need the neurosurgeon who are well trained in microsurgery and well knowledgeable in neuroanatomy. So welcome to this place with all of it myth. The first myth was that complete surgical resection is seldom possible due to the vascularity, invasive character, critical location, and often advance of the tumor and presentation. Well, surgical excision is the thing to be done, is the only thing in most of the circumstances. So this anti-surgery is something being carried on for a long time. And unfortunately, despite the proof that surgery is the way, with the successful way, this fear of surgery coming back again. If you just look back at 1968, Dr. Campi Atlas, a beautiful resection and instruction for a glomus jugulare tumor. My journey with the glomus is this patient. I was in the desert in Saudi Arabia in 82. Abdullah came back from Zurich. He had an operation on his glomus. You could in Zurich by Professor Fish, who made an amazing advancement in the treatment of glomus and jugular foramen. But you could see his approach, what used to be called the infra temporal approach, but did not go inside the CPA angle. So that the tumor grown bigger. Now it get a blood supply from the basilar artery and the branches of the vertebral artery, because it was embolized and they used to close the carotid for a tumor like this. And this case brought to me really all the issue we were facing and why skull-based surgery has to advance and thrive. We were living into anatomical border. Here the dura, the ENT man goes outside the dura, the neurosurgeon goes inside the dura. The wall, bigger wall than the wall of China. Cerebral vascularization. A tumor is involved with the carotid artery. Can you sacrifice it? Can you save it? Do you need to bypass it? Which one need the bypass? The extent of resection of benign tumor, is it really enough to remove subtotally or near totally? Or you really need a radical resection? If you do that, what the surgical morbidity, how much the price, what's the risk? And then it came later, what's the quality of life? And sitting above it all, the stifling of the authority. Oh, you cannot do that. You cannot do that. You shouldn't do that. Too dangerous. So one of the biggest problem was the anatomical border. Frequently, you will say it, we recommend the staging the operation, one for the ENT and the head and neck, and the other for neurosurgery. I saw many patients which they had the external extradural operation removed and being left with the larger tumor intradurally. Well, the moment to remove this intradural is when you have the beautiful exposure up to it extradurally. So I figured out that the time to approach both intradural and extradural is the same time. We came up with this approach that after doing the temporal bone drilling, you will open the dura and extend the dura to expose the intradural. And that's why cases that has large extradural present and intradural present need to be operated in the same time, in the same stage, from the same approach by the same surgeon. And here that Abdullah, then we went back The approach is already made for us, and it was easy to achieve total removal of the intradural. Here he is post-op. He had a partial facial. That partial facial, he had it before our operation. That partial facial, he had it because the approach which was popularized again by Professor Fish, that's to reach the carotid artery into the carotid canal. You need to drill the bone, and to drill the bone, you need to anterior mobilize the facial nerve. With the anterior mobilization of the facial nerve, this patient has a post-op facial paralysis. Luckily, that post-op facial paralysis was transient, like you see in this patient. Her facial nerve recovered. But then I thought, they're very unhappy patient because of that facial paralysis, and they a little anxious till the return of the function. So how you avoid facial nerve paralysis in the exposure of a large glomus tumor? Is this, instead of mobilizing the facial nerve, we drilled behind it and we drilled in front of it and kept the facial nerve into a canal protected in a bony bridge canal, like see both in the illustration and the actual operative slide. So that took care of the facial paralysis post-op. And since we started to keep that bony canal, you could see that the facial nerve paralysis is unlikely. Now, in many of these patients, you see the year they're operated, and I put it on purpose. That's these things is time tested, like 87, 88. That's more than 20 something years. We cannot re-challenge something proven. Something froze here, just bear for a second. But the worst things was the lower cranial nerve paralysis. Jugular foramen surgery was almost hunted by the frequent lower cranial nerve paralysis. It almost was considered that it's a must, it's gonna happen. And with it, that means you have a real morbid aspiration complication. And to avoid it, they had to put a tracheostomy and jejunostomy on everybody. It was horrible. So it was to really make jugular foramen surgery appealing and acceptable. We're going to have to find a way not to risk the lower cranial nerves. And to me, it became very obvious the lower cranial nerve are most vulnerable right here. Not in the CP angle, not in the neck, but right at the foramen fossa on the other side of the jugular venous bulb. So I thought if we keep that venous bulb, that portion only from the venous bulb, protecting the nerve that's outside it, we could save the lower cranial nerve function and remove the tumor from inside the sinus and the bulb. And we could monitor the lower cranial nerve throughout this procedure, and man, didn't work. Very frequently right now, we could remove all of the foramen magnum tumor by an all kind and maintain the good function of the lower cranial nerves. And that's just they made the big things. I have no hesitant to recommend strongly to the patient surgery in the jugular foramen now. And last but not least, that the infratemporal approach was calling for blind sac closure for the ear. So the patient lost their conductive hearing, even if the bony hearing preserved. So I thought we really want to quit doing that, keep the ear, keep the air, keep the middle ear. Sometimes the tumor extend into the middle ear, we could extract it from it, so we could preserve the joy of hearing. And it worked. I thought myself, oh my golly, we really figured it out good. Till the other day, I pulled out this atlas again and read Dr. Campi chapter on glomus jugulare. I tried when I was a resident to go and see Dr. Campi doing one glomus. I was not able to. I tried when I was in a practice and to go and see one by him. I wasn't able to. But now I read what he wrote. It's almost what I just told you. So before you invent anything, just read old books. And if there is something good, do not abandon it. Just make it better. If a facial nerve was a problem, do not abandon the infratemporal approach. Just find out how to protect the facial nerve, etc., etc. Now, here another problem in those glomus tumors. Frequently, you could see or hear that surgery was attempted, but had to be abandoned because of excessive bleeding. Sure. If you go into those tumors, oh, they bleed. The warning in medical school was that if the ENT person took one biopsy from the middle ear where that tumor was there, they bleed, we could not stop that bleeding. The answer not to quit operating on them, the answer to find out how you could operate with the minimal blood loss. And here the answer. To operate on a glomus with a minimal blood loss, you need to surround them totally. You do not enter them. Like all other hypervascular tumor like hemangioblastoma or like an AVM. You go around them, you surround them. And that's why they need a good exposure so you could go around them. You cannot do a glomus from a hole and debulk it. You cannot debulk a glomus. The other way is to embolize them. And I think embolization is very helpful in removing glomus tumor. Uh, it has its price. There is a complication of embolization. It has been known for a long time and did not subside, unfortunately. It's both in terms of a cranial nerve ischemia and maybe cerebral emboli. I was reading Dr. Valvanis, the great Dr. Valvanis, who probably embolized more tumor and more skillfully than anybody else. They were concerned about the complication of embolization. But I still believe the benefit of embolization outweighed the risk. Again, you gotta listen to person who had an experience. And here again I go that the majority of these tumors should be considered for preoperative embolization to reduce their vascularity and frequently their overall volume. This can make surgery for this tumor considerably safer. 1968, where embolization was endovascular was just about to be developed. So today, with the advancement of the endovascular, I think we could expect from our colleague to give us safer embolization. Just to tell you, this is one of the early patients I operate on 30 years ago. She was recurrent and previously embolized. You could see where the embolization on her scalp has spread. So by that time, there was a group of gliomas, which I call them the complex gliomas. They either been giant or been radiated or has closed the carotid before, and how to deal with them. So we're still in the idea of how to minimize the blood loss. One, you gotta surround them surgically. Two, you might get a real good help from embolization. But the three, to understand why the tumor bleed. These tumor has shunts. Look at this early arterial phase. You're already seeing the blood going down the venous jugular. They shunt. They're like AVM. So like AVM, the venous drainage has to be maintained to the very end to separate them totally from any arterial. I was called one time that the profuse tumor, profuse bleeding cannot stop the bleeding. And I came and look what I did. They ligated the jugular. So all what I had to do to stop the profuse bleeding from the blood is to re-establish the venous draining temporarily with bypass. Look at this. I put a tube. Look at the blood rushing in the tube. Didn't stop. But anyhow, the blood just rushed into the tube and the bleeding from the tumor surface stopped. Now, the last one in terms of the excessive bleeding is if you close a major sinuses, which glomus tumor do, and that start thrombosis inside the sinus, that will set up the pathophysiology of what we call dural AVM, like you see in this case. Large glomus tumor, close the dominant sinus, the sinus thrombose, sinus thrombosis cause dural AVM. Now, you're talking about bleeding. You could imagine how much bleeding you could get from dural AVM and from the glomus itself. So one should be aware of this happening, like we describe it in this article. Now, otherwise, how you deal with the glomus, you could see this is good size, not very large, but typical glomus with the extension down into the neck and with the relationship to the carotid artery. And the treatment then is to do the temporal bone drilling, exposing totally the sigmoid sinus and totally the jugular bulb, totally skeletonized. Keep the facial nerve into bony canal. Ligate the sigmoid sinus. Open the sigmoid sinus. A little bit more drilling to expose the bulb very well. After the bulb totally exposed, the neck dissection taking place, then open the bulb and the sinus, extract the tumor from surrounding it, free it from the upper neck from the carotid artery, and only then ligate the jugular and remove it from the neck down in the jugular. And then the last piece, it comes then to remove the intradural part. So here we section the dura. We are in the subarachnoid space. There is arachnoid plane separated the tumor from the lower cranial nerve in the subarachnoid space. A little better exposure. Oh, what happened? Sorry, it went backward. Here we are. And the real important trick is coming. Now, this is the intradural part. We remove the extradural part. We're separating the subarachnoid rootlet in the intradural part. And then following them up into the bulb. And look at this now. This is the last piece in the bulb. Look at the inner wall of the bulb when I take that patty out. You see the nerve? These are the lower cranial nerve into the jugular bulb on the other side of the venous, preserved. And that's why she could drink her glass of water postoperatively. Now, here, another things. The literature on a glomus classify them according to the size. It doesn't matter if it's a Glasgow-Jackson classification or Fish classification. And when they get big, that type 4 or D2, it's called inoperable. I disagree. The bigger the size, the more complex the tumor, but not the forbidden from surgical removal. So there is a category, I call them complex jugulary. Like this patient, it's a giant tumor. The carotid passed right into it. Somebody interfered in the pass and balloon occluded that carotid. So now you got all the blood supply coming from the basilar and the opposite carotid. They are hypersecretor, but they still, the only treatment for them is to totally remove them and amenable for that treatment. So when we took way back 43 complex glomas, giant, multiple, hypersecreting, they're all operable with no mortality. So if those complex are surgically treatable, then the small 2 centimeter regular glomas is absolutely surgery. Here's some reservation. This patient is a typical one. 1 paraganglioma, 2 paraganglioma, 3, 4, 5 paraganglioma, multiple paraganglioma. And now we look today at the glomas by the gene. Gotta find the SDH gene. And according to the CDH gene subtype, there is a 5 category of paraganglioma. One of them is really bad, and that is the CDHB. They turn to be more aggressive and multiple. Another one is bad is the D because it could be associated with other malignancy. Unfortunately, these genes get a transfer from the father to the daughter. So you could see that the matter of treating this patient get complicated with the guilt that it's been transmitted to the patient from their parents or from the father in particular. These days, it's a very easy to discover all the paraganglioma with the dentate PET scanner, dentate PET scanner. So the workup of glomas these days would include dentate scanner to look for any multiple paraganglioma and would include the genetic study looking for the SDH variants. That automatically will put you in which category your paraganglioma is and what the best treatment options. So please, every glomas, get on them if you can available, dentate PET scanner and genetic analysis. Because multiple paraganglioma, it's not what you see today on that MRI of one tumor you rush to operate on or radiate. The risk of those patients that they might end with bilateral cranial nerve deficit. Can you imagine somebody with bilateral 7 or worse with bilateral lower cranial nerve? So we should think of them as lifelong management and not what you see today, but what might happen in the future. So we don't transposition facial nerve, we don't injury facial nerve, we don't injury the lower cranial nerve, we don't. Here an example, a young lady had the glomas and carotid body on one side and carotid body on the other side. I took the glomus and carotid body from one side, but I left the other side and observe it because she cannot afford bilateral lower cranial nerve deficit, and followed her for years, being able to drink. Otherwise will be permanent tracheostomy and jejunostomy. Many of the multiple are on the same side. Like this, you could see carotid body and she had jugular foramen. The time to remove them both is that same session because with the surgery of a glomus, you do neck dissection. And with the neck dissection, if there is a carotid body tumor, you take it out. But here a patient where his carotid body tumor is on the other side. So he got the glomus on one side and the carotid body tumor on the other side. So what to do? He's intact, both sides. What we did after the patient understand that let's get the carotid body tumor out first, because the risk of giving lower cranial nerve deficit is smaller. It's there, but it's smaller. And when we're comfortable that we got rid of that tumor and he's still functioning well with the cranial nerve on that side, we attack the glomus on the other side. So here, you see separating of the carotid body tumor. Very carefully maintaining the function of the 10th. The tumor comes from fascicle of the 9 at the carotid body, which you could separate them right there and be able to remove the carotid body without risk to the cranial nerve. There is a plane between the adventitia and the tumor. And that's why I need the microscope to find that plane. So the idea that you have to resect the carotid with this is non-existent. The idea that the 10th nerve will go, no, you could free it. And you could see here the vagus. Anyhow, I'm bringing in this because aside from the carotid body and the jugular foramen, there is this paraganglioma. You can see it very typically push the carotid artery way anteriorly and medially. It's called carotid or glomus vagale. There is very hesitant to remove them surgically because the chances of having a cranial nerve deficit is very high, as listed in the literature or in the ENT colleague you talk to. I can categorize them in the past, but I never was hesitant to operate on them and remove them. And here that little girl, here another one. And you could see that as you operate them, you could get the 10th nerve and you could establish a plane between the tumor and the 10th nerve as you establish it from the carotid adventitia. You see how right there, that's where it started from the nerve, and we're trying to separate it. It's gone. Oh. Now I'm gonna skip here for the time because I think we're getting short on the time. But we go to that guy who had carotid on one side and the glomus on both sides. We got them both. The hearing is diminished, but it's still present, and he's enjoying his Diet Coke. Again, as I told you way back, we look into the really complex cases, the multiple, the giant, and thanks God we had zero mortality. There was CSF leak in 4, and hemiparesis temporary that improved. One of them was from vasospasm of the carotid that been open with papaverine injection. So we talk about being giant or multiple or being compromised before with treatment. But here another thing. There is secretor, most commonly the catecholamine secretion, but it could be the other things. If they secrete catecholamine, it will be like a pheochromocytoma. You will have a major intraoperative crisis if you did not prepare them. And these days, you could measure the blood pressure, the blood level of epinephrine and norepinephrine, and if it's 4 times higher than normal, then they're hypersecretors. And this could be treated with a blocker. The blocker has to be alpha and beta. You gotta start with alpha blocker first. You do not give beta before alpha because you will have a crisis then. But right now, you give them like lapiridol. It's the same time alpha and beta blocker. Now, but here a beautiful young lady from Turkey. All her complaint is tinnitus and has perfectly exam. But like all the good neurosurgeon and doctor in Turkey, she had a very thorough workup, including that her dad is found with the SDHA, and her dad had the sarcoma, which is known to be associated with SDH. So she's at a high risk of malignancy. And that's her tumor. Giant. Oh, giant, we know how to treat giant tumor. Let's embolize her, and we operate her. So we embolize this girl, ready to operate her. Her catecholamine, epinephrine, and norepinephrine normal. Look at this. Till that night, my good nurse, you need a team, kept insisting from the lab across the country that we want the dopamine. And it was sky high. Very rarely glomus reported to deal with known to be hypersecretor of dopamine. Well, we know what to do with epinephrine and norepinephrine. We give them lapiridol, or anesthesiologist knows how to handle them. We know how to prepare them, but what do you do with dopamine? We didn't find anybody had experience. We found about 13 cases reported in the literature, not glomus, but any paraganglioma with high dopamine. 2 of them died on the table. So the risk of surgical intervention of this dopamine things is so high. And not just so high, couldn't really find in the literature or by asking around the expert how to deal with the crisis if it happened. So I sent her for radiation. 3 years later, she's happy, her dad happy, I'm happy. We did not run into crisis that we don't know what to do about it and has high risk on her life. Here another patient, operated in 70 in Hugo Fish, in Bill House, then Hugo Fish, then had the radiation, then had the operation, then had what have you, and now he has a big recurrence. Look at this tumor. We discussed him, we're gonna embolize him, we need a free flap to close the huge defect we're gonna cause, what to do with his cerebral collateral, a big elaborate surgical plan that we should. He has other paraganglioma, we figured out how we're gonna deal with them in the future till his dopamine came down sky high again. Not knowing how to handle dopamine crisis, I send him for radiation too. Now, took too much time talking about the glomas. Do I have more time to keep on going?
Professor. Yes, Professor, of course. Yes, please.
But you need to be sure of the diagnosis before you go to surgery or have surgical plan. Glomus is not the only tumor in the jugular foramen. You got meningiomas, you got schwannomas, and you got glomus, and then you got the others. But the difference between how to handle glomus and schwannomas and meningioma is big, so you gotta have the diagnosis in advance, and the diagnosis is easy, readable by both MRI and CT scan. They're complementary. If you see expansion, this is a schwannoma. If you see hyperostosis, this is meningioma. If you see the bony destruction, that glomus. And then you treat them accordingly. So this beautiful schwannomas, expanding the foramen, preserving the sinus drainage, does not need to go through the sinus, does not need to ligate the sinus. It's delight. Schwannomas everywhere are delightful and equally in the jugular foramen. The risk of having lower cranial nerve paralysis with the glomus much higher than with the schwannomas. I really don't remember the last schwannomas had their swallowing difficulties in the jugular foramen after resection. It's like an acoustic. You remove them and preserve hearing. It's like facial nerve schwannomas. They're frequently a dumbbell shape with intracranial extension and extracranial extension, but they're always amenable to total removal with the preservation of their cranial nerve functions. I love schwannomas, and I think every neurosurgeon should. Now, here the trick, many of them, the sinus is still open or only compressed. It does not need to be removed. So in this schwannoma, you could see the sinus is still, it's just compressed, it's still open. So we need to do this operation without to sacrifice the sinus. Yes, we could do this operation from what I described, the suprabulbar approach. It's a window you make above the jugular bulb and below the labyrinth and in the front of the sinus. You see, you get your segmentation does by this, the great Dr. Kyle Wu here. You could see how the sinus running. You could see that there is a big draining vein out, but you see that there is a window right here. So that window, you could directly goes to it on top of the jugular bulb. And here it is. We're drilling the mastoid, preserving the facial nerve in its canal, drilling in the front of the sinus, on the top of the jugular bulb, below the labyrinth, and you could see the window. Look at the navigation where we are, right where we want to, under the labyrinth. And down there, enlarging it, just on top of the bulb, but not entering the bulb. We got a window of about 2 centimeters. With the schwannoma, it's soft, they're suckable. So window like this, it's more than adequate to remove that tumor. And again, the schwannoma coming from a little fascicle and frequently from the 9. So you remove that schwannomas from that window by continual suction. But then what you're gonna do out more lateral and where you don't see it with the microscope. Then to follow the tumor out lateral where the direct scope does not show you, you bring the endoscope. And this is a perfect place for the endoscope, microscope. You change from one to another. It's not just inspecting at the end. You do endoscopic dissection and you do microscopic dissection and alternate as is needed. Now here we're testing the internal carotid. You hear the carotid? That's the carotid on the other side of the jugular bulb. Now, what I'm saying, endoscopic technique we should all learn. And endoscopic technique is a technique different than microsurgical technique that require practices. But it's not either or. One has to be proficient by both. Now, so here it is, gone. Result is published. Will I ever then give radiosurgery, gamma knife, to a lower cranial nerve schwannomas? There was one case, young, great lady, have a little tumor. But look at that, all of her brain venous drainage go through that sinus, which is still open. I was so hesitant if that sinus thrombose or bleed or injured, that it will be disaster, because that's the draining route of all of her cerebral circulation. Now the last is meningiomas. Meningioma, it depends what they're doing in the sinus. The one which is closed the jugular bulb will do it like the glomus and open the jugular bulb. The one which is mainly behind the sinus, we do it in retrobulbar. But the one which is still open the sinus and present in the front of the sinus, we could use that same window I showed you. So this one, it's already occluded all the jugular bulb. We did it like the glomus by ligating the sinus and open. This one, the sinus is open, the tumor in the front. It's not available behind the sinus. We don't want to close the sinus. So we did that suprabulbar approach I told you. Here we are, that window we were talking about, on top of the jugular bulb, below the labyrinth up there. Here the lower cranial nerve. The 7 is way up there. And we're removing the tumor through that window, both out in the jugular bulb and the part inside, like you see the intradural part, dissecting it free, which is good. I cannot emphasize to you enough that the horror from lower cranial nerves we could overcome, and that many jugular foramen patients can be operated and the tumor can be totally removed without the morbidity of lower cranial nerve deficits. And that makes the whole world different, because that the lingering things, the quality of life, so you don't remove the tumor because the quality of life, it will take that excuse away. Now, just to close then, the best of the jugular foramen is the schwannomas. Meningiomas do well. Glomus, there is a lot of issue need to be attended to in the workup. And then you get the zebras. This is one of them, chondrosarcoma. It's gone. Lower cranial nerve. And what your reward, what your $1 million or $1 billion, if this is a statement, look at it. Thank you so much for saving my hearing among all other vital function of my brain. I can assure you I listen to music and life with gratitude. If you could preserve the hearing and the swallowing in jugular foramen, you can not get bigger reward than the gratitude of those patients. Thank you.
Professor, thank you so much. Thank you so much for this excellent lecture. We have two questions for you, if it's okay.
Absolutely. Let me close my.
Yeah, of course.
Okay, here.
Yeah.
He threw me out.
Yeah, the first one is, in case of glomus jugulare tumors, is there any need for exposing the VA, vertebral artery, or resection of C1 transverse process in glomus jugulare tumors? VA exposure and any need for transverse process C1 resection?
Yeah. That approach we're talking, and you see the vertebral, obviously, and many times there is a little blood supply coming from the vertebral, from the muscular branches, which you take them down. But you don't have to mobilize the vertebral like we do in foramen magnum tumor, meningioma, and transcondylar, because you're going to be in front of it. So yes, the vertebral will be in the field, but does not need to be dissected.
Resection of C1 transverse process.
It's not in vertebral. I mean, not in jugular foramen tumor, because they come along the jugular vein down in the neck. They could expand all the way down to the bifurcation of the carotids. Now, what I do frequently, because I see those tumors that extend in the foramen and down the neck, the safety here is the carotid artery, how to separate them from the carotid artery safely. And that means you gotta get the carotid artery as it pierces into the skull. The carotid artery as it pierces in the skull is covered or crossed by the styloid process. So I remove the styloid process in many of these cases.
Perfect.
But not the C1, the styloid process up front.
Mm-hmm.
I just noticed something I want to show you. Look at behind me. I'm in my office, and look at my behind me here. Something I'm very proud of, it hanging on the wall. A honorary membership in the Turkish Neurosurgical Society. So I'm always grateful and proud of neurosurgery in Turkey.
Well, I think we are done. One last question, Professor, is about staging. They ask about, these are long procedures, and the surgeon may get tired, and what the professor thinks about the staging of the. That's a general question. That was a general question. So your thoughts?
Yeah. Now, schwannoma and meningioma, they do not take that long, so there is no question. What left is the glomus, if they're gonna take that long. But the glomus, you really cannot quit in the middle. You're gonna have to surround the tumor and get it out. You cannot quit in the middle of. So I have not been staging a jugular foramen tumor. But here the things. This people, this type of cases, need a team. You need that scrub person or surgical assistants knows what they're doing, knows your equipment, have been with you, you know what to do. Equally so the anesthesiologist. And in many institutions right now, it's hard to keep the team for lengthy cases. You know, the shift time has come and it's over, and then you might get people who are not familiar with this long, difficult cases. And this situation might be forcing people to stage. If I don't have the people whom I'm comfortable to work with, and I better come on another time.
Well, thank you very much, Professor. Thank you for your time. We learned a lot. Let me hand it to Professor Avcı. I think we can close.
Yes, yes.
Please.
Thank you, Professor Al-Mefti. It was a great presentation as usual. And I hope we will see you in the real Congress, face to face. Thank you very much. Thank you very much.
You're very welcome, Emil. Thank you. And I hope to see you all soon too.
Okay. Bye-bye, sir. Thank you. Bye-bye.